Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today we're really excited. We kind of have a master class in CRRT coming up. And if CRRT's ever felt confusing, continuous renal replacement therapy, fragmented, overly technical, you just kind of go with the flow, yeah, they're on CRRT. Well, let's understand it. This video is what brings it all together. Today we're building a continuous renal replacement therapy from the ground up type of episode. We'll start with why we use CRRT in the ICU, when to choose it over intermittent dialysis, core principles of solute and fluid removal. And then we'll go even deeper. We'll break down the different types of CRRT, including CVVH, CVVHD, CVVHDF. We'll talk about them step by step. What are they, when to use them, what they're good at, what they're not good at, convection versus diffusion, replacement fluid versus dialysate, effluent dose clearance, practical bedside decision making, right? All these really, really important concepts to start to understand. By the end of the episode, you won't just understand CRRT, you'll understand how to think through it in an actual critically ill patient. So no further ado, let's dive in. Today, we're going to be talking about continuous renal replacement therapy, or CRRT. Specifically, we're going to kind of dive into the basics of this. We're going to talk about the different components of renal replacement therapy, continuous renal replacement therapy. We're going to talk about the different types, CVVH, CVVHD, CVVHDF, are all different kind of types under the umbrella of continuous renal replacement therapy. We'll talk about the parameters. We'll dive into how to use CRRT. We'll dive into the different components, all that good stuff. So, CRRT stands for Continuous Renal Replacement Therapy. And this is a group of dialysis modalities used primarily in critically ill patients with AKI who are hemodynamically unstable. Now, you can have patients who, instead of AKI or acute kidney injury, have end-stage renal disease, ESRD, and are on intermittent hemodialysis at home or in the outpatient setting, but now they're critically sick and hemodynamically unstable, and as such they require this slow, continuous fluid and solute removal, that they're not able to tolerate their intermittent hemodialysis anymore. CRRT mimics the kidney's continuous function over 24 hours. It's continuous. It goes for 24 hours. Unlike intermittent hemodialysis, which usually runs for 3 to 4 hours, and is much more kind of hemodynamically disruptive to patients. So CRRT, continuous renal replacement therapy, we usually use in our critically ill patients with hemodynamic instability. It is for either acute renal failure or end-stage renal disease who is now critically sick and needs dialysis, and it's slow, it's continuous, and it runs over 24 hours. So why use CRRT in the ICU? Well, as we mentioned, you can do intermittent hemodialysis in the intensive care unit, of course. So when do we use continuous renal replacement therapy, CRRT? As we mentioned, hemodynamic instability is probably the biggest one. Because it's continuous, there's slower removal of fluids and solutes, so hypotension is better tolerated. Now, make no mistake, those that are critically ill, those on multiple vasopressors, this still can worsen their hemodynamic instability. This is not completely benign from a hemodynamic standpoint, but it is much more stable than something like intermittent hemodialysis or even slow, low-efficiency hemodialysis SLED, which we've talked about in previous episodes. Again, linked in that nephrology playlist in the description of this episode. If I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have
a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients.
Volume overloaded patients are another subset because we actually can get pretty fine control of their fluid balance. On CRRT, we can, set them. We want them to have net negative 100 cc's per hour. So this is that their ultrafiltrate, their UF, how much fluid we're removing from the body. We want it to be 100 cc's removed per hour. That is just discarded. So you have really kind of fine control over the volume balance. Cerebral edema is another one. CRRT is very gradual, it's very slow. So the solute shifts that occur with continuous renal replacement therapy is much slower and gradual. And some would suggest that this helps patients with intracranial injury because there's not this fast movement of solutes. Now, this is a little in the gray. It's not totally clear, but a lot of folks kind of abide by this. And then obviously severe acute renal failure with multi-organ dysfunction. CRRT, sometimes the best modality given that hemodynamic instability. So what are the components of continuous renal replacement therapy? Well, you obviously need vascular access. You need some way in which you can hook someone up to the CRRT machine. And this is typically a large bore double lumen catheter. We most often place it in the neck, in the internal jugular vein, or in the groin, in the femoral vein. And these two lumens, one of them draws blood out of the body to the dialysis machine, and then the other one sends post-dialysis blood from the machine back into the body. And they need to be large bore. A lot of people use verbiage like trialysis is a big one that we sometimes will use to place this. They need to be large bore because they need to have a really high flow rate. Sometimes like 100 to 200 cc's per minute of blood flows through here. So they can't be small. They got to be large bore. And there's particular dialysis catheters that we often place to do this. You need a pump. Right? The machine needs a pump. The pump draws the blood through the filter. Again, typically 100 to 200 cc's per minute of blood flow. That is literally flowing from the patient into the dialysis machine and then out of the dialysis machine back into the patient. You also need a filter, often called a hemofilter. This is that semi-permeable membrane where solute and water exchange occurs. So this is the membrane that the blood passes by and through that helps purify the blood, right? It helps remove solute from the blood. It helps remove water from the blood. This filter, this semi-permeable membrane, is critical for the function of dialysis. Then you need either replacement fluid or dialysate. And in one of our previous episodes, we dove into what these two are. We're going to briefly touch on them here, but definitely check that out, okay? Again, it's linked in that nephrology playlist under CRRT. But the replacement fluid is the fluid that we pump into the patient's blood to then be given back to the patient. And the reason we do this is for some modalities of CRRT, particularly, and we'll talk more about all these things, CVVH, which is continuous veno-venous hemofiltration. It uses something called convection. Okay, convection is where you pump blood past this semi-permeable membrane, and water from the blood and solutes diffuse out of the blood into a separate chamber that then is discarded. And you sometimes then need to give replacement fluid back into the blood to make up for some of these losses. And this is something you can calculate. You can give it in a couple different ways. This says before or after the filter, which again we dived more into in that other episode. Then dialysate is another possible fluid you need. And this is for CVVHD, or continuous veno-venous hemodialysis. Again, we'll talk more about these modalities, which uses diffusion, which is when you pump blood past this filter, this membrane. The blood comes down, B for blood. The dialysate is traveling parallel, but counter current. And essentially the dialysate creates a concentration gradient between the blood and the dialysate, so then things diffuse down their concentration gradient into the dialysate, which is then discarded. So depending on the modality of CRRT you're using, you'll need either replacement fluid, dialysate, or both. And then many circuits need anticoagulation, and the reason is because you're blood flow rate is much slower for continuous renal replacement therapy than it is for intermittent hemodialysis, and with slower blood flow, you have a higher risk of clotting. Now, this is all either citrate or heparin. Both of these can be used, and not all CRRT setups use anticoagulation, but if you don't, you run the risk of clotting your circuit. So many of them use citrate or heparin, but you can do this without anticoagulation. You just run the risk of clotting your circuit. All right, 4 types of CRRT. This is where we're kind of diving into these different modalities, and we're going to talk about each individual one in detail. So we're just introducing them right here, and then we'll dive more into them. So there's 4 subtypes, and really it's like 3 subtypes plus another one that's sort of like CRRT. And if you didn't notice, CRRT is an umbrella term. Continuous renal replacement therapy is an umbrella term that then includes these, I guess we'll say 3.5 different modalities, which are different types of CRRT. And they're distinguished by their mechanisms of solute removal, okay? So when we're looking at these, the first 3 are CRRT modalities, and then this last one, SCUF, is a CRRT, but it's just a little bit different in terms of how it works. So focusing on the first 3, you'll see CVV in all of them. CVVH, CVVHD, CVVHDF. And I want you all to just ignore the CVV part of this, because the CVV just stands for continuous venous, right? It just means continuous blood drawn from one vein into the machine and then put into another vein, continuous venous. And that just leaves us with less letters to focus on. So CVVH, if we ignore the CVV, it's really just H. CVVHD is really just HD. CVVHDF is really just HDF. Okay? CVVH, the H stands for hemofiltration. And this is important. HD for CVVHD stands for hemodialysis, and then HDF for CVVHDF stands for a combination, hemodiafiltration, a combination of dialysis in the dia, and then obviously filtration in the filtration. So you're starting to see some patterns emerge now, right? Hemofiltration, hemodialysis, and hemodiafiltration. And the reason there's different verbiage here is because the way in which the CRRT modalities work is different. They're slightly different for how they get rid of solute. CVVH, which is hemofiltration, uses convection. So anytime you see hemofiltration, I want you to equate in your brain to convection. Whereas hemodialysis, CVVHD, the hemodialysis stands for diffusion. Anytime you see hemodialysis, equate it in your brain to diffusion. Which then leaves hemodiafiltration, which is a combination of dialysis and filtration. So it's a combination of diffusion and convection. All right, does that start to register a little bit? Obviously still very confusing, but the convection, diffusion, filtration, dialysis are all kind of patterns you could pick up in your head that then help you clue you in later on. So just to say it quick, because we're going to dive into each of these types, we just wanted to take a moment to pause and talk about the difference between convection and diffusion. So for those listening to the podcast, we are going to draw a little diagram here. Apologize, but we'll vocalize it best we can. So the top is going to be diffusion, top diagram here. And the bottom diagram here is going to be convection, okay? And what we have here is the middle line is a filter. This left side is going to be blood, and this right side will change depending on the modality we're talking about. So essentially, blood is drawn into the dialysis machine, and it runs by this filter. And this filter, as we said, is a semi-permeable membrane. So that happens in both diffusion and convection. Blood is taken into the semi-permeable membrane. Diffusion, though, what happens is the semi-permeable membrane has these really small pores in it. And what runs parallel to the blood is dialysate fluid. Okay, it runs countercurrent but parallel to the blood. And as this blood runs by this filter that is also in contact with the dialysate, the solutes in the blood will diffuse across this filter down a concentration gradient. So if there's 10 molecules hypothetically in the blood, and there's 2 molecules hypothetically in the dialysate, then these molecules will diffuse into the dialysate until there's 5 on each side, right? This is diffusion. It goes down a concentration gradient. And this dialysate fluid then just gets rid of it. It's discarded. And that is how you clear solute in diffusion-based CRRT modalities. And as we said, diffusion, equate it to dialysis, which would be CVVHD, right? Continuous veno-venous hemodialysis, and CVVHDF, which is continuous veno-venous hemodiafiltration, but the dia portion of that is dialysis. So these two use diffusion. Convection's different. Okay, convection blood runs parallel to the semi-permeable membrane, but the blood flow and the pressure actually forces plasma water out of the blood through these pores into this other chamber. And what happens then is solute follows. There's some solute drag that comes with this water. And that is how it gets rid of plasma water and solutes. It's more of a hydrostatic pressure with semi-permeable membrane leading to plasma water going through this membrane and dragging solutes with it. And then this is discarded. So in convection, there's no dialysate. Okay? There's just this semi-permeable membrane that water from the plasma goes through, and it drags solute with it. Remember, convection, we said we equate that to hemofiltration. So this is for CVVH, continuous veno-venous hemofiltration, and CVVH HDF, right? HDF is hemodiafiltration. So the filtration portion of that is all convection, okay? So that's going to come into play a little bit more when we dive into each one of these different CRRT modalities. SCUF is its own beast. So SCUF is ultrafiltration only. This is only for fluid removal. There's no dialysate. There's no replacement fluid. It is just fluid removal, ultrafiltration. You can remove a lot of fluid this way, though. So we don't use SCUF all that often. The only time we can really think that you might consider using it would be if a patient was just profoundly volume overloaded and you just wanted to remove a bunch of fluid, but it's not commonly used. All right, let's go into these modalities a little bit more, starting with CVVH. And even though CVVH, it'd be nice if it was CVVHF, it is not, but it stands for continuous veno-venous hemofiltration, right? And hemofiltration, we said, anytime we see filtration, we should correlate it with convection. So the primary mechanism of CVVH is convection. That's how it gets rid of solute. So there's no dialysate. This is convection. The blood flows past this membrane, and the hydrostatic pressure leads to plasma water going through the membrane, and that drags solute with it. So that's how it works. Plasma water and solutes are dragged across a semi-permeable membrane, also known as solvent drag. You do need a replacement fluid here. And this is a fluid that you can make up with different components. And this helps you maintain your fluid balance because remember, you're dragging plasma water across this membrane to then be discarded. So you're getting rid of plasma water. And you then replace this with your replacement fluid. And you can either do that pre-filter, so you can essentially mix, excuse us, let's get a drink quick. Our bad. You can essentially mix the blood with your replacement fluid and then have it pass through the filter. This prolongs filter life, but it does reduce clearance slightly because you're kind of diluting out that blood. Or you can have replacement fluid post-filter. So the blood goes by this filter. That filter obviously does the solvent drag where plasma water and solutes are dragged across and discarded. And then you mix what's left of the blood with the replacement fluid. This lands for better solute clearance because you haven't diluted the blood before it passes that filter. But it does also lead to shorter filter life. So this is best for patients with sepsis, inflammatory mediators, hemodynamic instability. Convection, people say, is better for kind of larger solute molecules, things like myoglobin, cytokines, all that kind of stuff. Okay. CVVHD, continuous veno-venous hemodialysis, right? We said anytime you see dialysis, think diffusion. All right. Whereas again, anytime you see hemofiltration, it's convection. So primary mechanism for CVVHD is diffusion, which, as we said, solutes move across that membrane along a concentration gradient using that dialysate fluid. The dialysate flows countercurrent to the blood, and there's a certain flow rate of the dialysate fluid. The higher the dialysate fluid flow rate, the more efficient your removal of solute is going to be, which makes sense because the solutes are moving across a concentration gradient. So if you let the dialysate get totally saturated with solutes, that concentration gradient goes away. So if the dialysate is flowing faster, there's going to be less there's going to be better preservation of the concentration gradient because that dialysate will not have time to get a bunch of the solutes in it because it'll just keep flowing by quickly. This is best for small solute clearance, urea, creatinine, and mild fluid removal, so it can't remove as much fluid. So CVVHD is better for small molecules. CVVH is better for larger molecules. This then gets into the combination maneuver, CVVHDF, continuous veno-venous hemodifiltration, right? Why make any of these words easy? But the more you think about it, you probably have to watch this video a couple times, the more this starts to register. So this has both dia, which is for dialysis, which is diffusion, and filtration, which is for convection. So it's both diffusion and convection, and that's the mechanism of CVVHDF. So it combines CVVH, which is hemofiltration, which is convection, and CVVHD, which is hemodialysis, which is diffusion. And that means it uses both a replacement fluid, which is most typical of CVVH, because it uses convection, right, which has that plasma water with solvent drag, and CVVHDF uses dialysate because it has a hemodialysis, which uses diffusion, which needs a dialysate running. So it's a combination of those, CVVH and CVVHD. It's best for maximizing clearance of small and larger molecules, excellent in critically ill with high toxin load or multiple indications. I think many people in the intensive care unit kind of use CVVHDF as a standard, which is nice. And then SCUF, as we mentioned, is this kind of enigma. It's slow, continuous ultrafiltration. It just uses ultrafiltration to remove fluid only. It's pure volume removal. There's no dialysate. There's no replacement fluid, but you can take off a lot of fluid. You can take off, 100 to 300 cc's per hour, sometimes even more. And this is really only good for fluid overload patients without significant need for dialysis otherwise. They don't have significant electrolyte derangements or acid-base disturbances or uremia or what have you. So the operational parameters that we should keep an eye on and think about, and we've talked about all these in some of the introductory videos, so you can definitely check those out. But blood flow rate is important. This is the rate of blood that's being removed from the body and running through the dialysis machine. It's usually 100 to 200 cc's per minute. And this is a lot lower than intermittent hemodialysis, and this is what really reduces that hemodynamic stress. But it is 100, 200 cc's per minute, so you are removing blood from the body, so it will cause some hemodynamic instability, but much, much less than other dialysis modalities. The effluent rate is the amount of fluid kind of being discarded. This is usually a combination of the ultrafiltrate of any dialysate that's running through, sometimes of even any additional fluid, replacement fluid given, depending. The thing with the effluent rate is this is how you kind of dose your dialysis therapy, and you usually choose 20 to 35 cc's per kilogram per hour. Some stay starting at 20 to 25, but 20 to 35 cc's per kilogram per hour. This is how you dose your dialysis, unless you're a nephrologist or some critical care shops have you write your own CRRT orders, but this is a little more complex than just the run-of-the-mill understanding of this stuff. The ultrafiltration rate is patient-specific. This is how many cc's you're discarding of the patient's volume. So if I'm saying I want this patient to I want to eliminate 100 cc's per hour. I want to essentially say I want them net negative 100 cc's per hour, and that is the ultrafiltration. So the ultrafiltration is negative 100 cc's per hour, which means I'm taking that patient's blood, I'm running it through the dialysis machine, it's filtering out 100 cc's of plasma water, and then it's just discarding it, it's getting rid of it, and the rest is going back to the patient. So that's the ultrafiltration rate. And then the replacement or dialysate rate, 1 to 2 liters per hour, and this, depends on the modality, right? We said replacement fluid is for convection, which is going to be CVVH and CVVHDF, and the dialysate rate is for diffusion, which is going to be CVVHD, and still that CVVHDF, which is a combination, right? Good. One thing to note is anticoagulation in CRRT can be really important. The blood, as we said, blood flow rate is much slower than IHD, so there's more risk of clotting. Most shops will use either citrate or heparin. Citrate is usually preferred if there's bleeding risk present. It's regional. You put it in the dialysis machine itself. It binds to calcium, which then prevents clotting in the circuit. This is just like why you have citrate in blood transfusions, because it binds the calcium and it helps with clotting. Now, other shops use heparin. That's if there's no contraindication to anticoagulation. Sometimes you got to monitor PTTs. Some dialysis machines can have heparin in circuit, but some you have to do it systemically. Now, if there's a high bleed risk, or if you are okay with a shorter filter life, no anticoagulation is an option, but that filter might clot, which means you might have to replace it, and it might require frequent filter changes, which then limits the utility of your therapy, obviously, because every time you have to change the filter, you have to stop the dialysis, blah, blah, blah. So depending on where you work, you will have different approaches to this. Usually the hospital and all the stakeholders have agreed on some approach, whether that's start with no anticoagulation and then flex to heparin or citrate, or whether that's to start with something like a citrate protocol that you just do for all your patients. If we lay out the differences between CRRT, IHD, and SLED, we've dove into this in huge detail in previous episodes, but we just wanted to briefly cover it here. The duration is one of the big differences. CRRT runs 24 hours a day, all day long. Intermittent hemodialysis only is 3 to 4 hours, and then SLED is this slow, low-efficiency dialysis. It's in the middle. It's 6 to 12 hours. The hemodynamic impact of these, CRRT has the lowest hemodynamic impact. It still has some, but it is the lowest. Intermittent hemodialysis has the highest hemodynamic impact because it, runs over the shortest period of time. So blood flow rates are super high, etc. SLED is an intermediate hemodynamic impact. Solute removal for CRRT is slow. This can be really important if you have someone with a toxic ingestion and you want to remove some toxic solute quickly. IHD is the fastest. It's rapid solute removal, where CRRT is quite slow. SLED, again, is in between, moderate. And then CRRT is mostly used for unstable patients. IHD is mostly used for stable patients. And then SLED is kind of this in-between hybrid semi-stable maneuver. So finishing with some clinical pearls. CRRT is not one size fits all. Match the modality and the clinical goal. Are you trying to remove volume? Are you trying to remove solute? Or are you trying to remove both? CVVHDF, hemodifiltration, is the most comprehensive but also the most complex, right? This combines hemofiltration as well as hemodialysis. And as we have talked about, dialysis is diffusion, filtration is convection, so it combines convection and diffusion into a single modality. If you do have a citrate protocol for your anticoagulation, citrate can accumulate. It can cause hypocalcemia, metabolic acid alkalosis. It can be quite significant, especially in liver dysfunction, so you got to monitor for that. Filter clotting is a complication. You should see increased transmural transfilter pressures, and you can consider pre-diluting for CVVH or CVVHDF, right? Those modalities that have replacement fluid, or adjust your anticoagulants. And then, don't rely on BUN or creatinine alone to determine the need. We talked about in previous videos those emergent indications, A, E, I, O, U. These are what should drive when you start CRRT in your unstable patients. And we do have some suggested reading down here if anyone has an interest.
All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day today. Hope people have enjoyed some clinical shifts recently maybe, or learned something new, all that good stuff. Today we're going to be diving into a really important topic, and also one that's a little more complex. I think in the clinical arena we sometimes get away with not necessarily knowing the difference between different modalities of CRRT, or continuous renal replacement replacement therapy. Level up your medical knowledge faster. Join a community of like-minded individuals interested in emergency critical care medicine. Consider joining our YouTube members community. In this community, you will get early access to new videos before they go public, members-only videos including deeper dives, bonus content, study guides, and more, and members-only medical education posts, updates, extra learning resources, and much more. If you're serious about mastering emergency critical care medicine or just want to join a community of like-minded individuals, this is the best way to learn with us every single week. If interested, hit that join button, and I hope to see you inside the community. But there are a couple different modalities, and they do different things, and they're good at different things. And that's what we're going to deep dive into today. On the channel, we have put out a whole bunch of episodes on renal replacement therapy and continuous renal replacement therapy. Those were kind of broader overviews, though. This is going to be a deep dive on a particular kind of renal replacement therapy, and that is continuous veno-venous hemofiltration, or CVVH. All right? And this is going to be one episode of several that go into CVVH, CVVHD, CVVHDF, a comparison between them all, and all that good stuff. So if you're interested in the topic, just go ahead and search whiteboard medicine and then CVVH or CVVHDF for continuous renal replacement therapy or what have you, and you'll be able to find all these. Also, the PDF for the study guide from this video will be available on our Patreon page, as they all are. And then lastly, before we dive in, remember, none of this is intended to be acted upon as medical advice. Please check out the full disclaimer in the episode description or at the end of the episode. All right, let's dive in. What is CVVH? So as we said, CVVH stands for continuous veno-venous hemofiltration. And that kind of explains to some extent what it does, right? It's a continuous modality. That's in comparison to IHD, which is intermittent hemodialysis, right? So you're on CVVH continuously, 24 hours a day, 24 hours a day, 7 days a week. It's veno-venous, right? Because this is dialysis. So it takes blood from a vein, goes through the machine, and returns blood to a vein, veno-venous. And then it's hemofiltration. That's going to be in comparison to hemodialysis, which is going to be in comparison to hemodiafiltration. And they all mean different things. In this case, the filtration, which we'll get into, is an indication that this modality of continuous renal replacement therapy uses convection to clear solute. All right, so CVVH is a type of continuous renal replacement therapy. CRRT is what we abbreviate it as in the clinical arena, and it removes both fluids and solutes from the blood, primarily through convection or solvent drag, which we'll talk more about. And this is designed, it's a good modality designed for critically ill patients who cannot tolerate intermittent dialysis. And that's most often because of hemodynamic instability, right? Intermittent dialysis pulls just dozens of liters of fluid per hour. And as such, pulling that much fluid out of the body and returning it to the body is very hemodynamically challenging. So if a patient's really sick, they're in shock, right? They're hypotensive, or they're just kind of critically ill and they don't have a good ability to compensate, to auto-regulate. Intermittent dialysis often can cause significant hypotension, which then is a barrier to completing the session of dialysis, right? Because you can't just, make someone more and more hypotensive while they're getting intermittent dialysis. So CRRT, continuous renal replacement therapies such as CVVH are good for these hemodynamically unstable patients. So core concept, just to introduce it, CVVH removes plasma water across a filter. All right, that is convection. Solutes are dragged with that plasma water. So then the fluid that's been removed, there's often a replacement fluid to help you kind of navigate the volume in which you want to actually remove from the patient's body in total. Again, this is just introducing the concept. We're going to dive deeper into this as time goes on. So you can think of it kind of squeezing plasma water through a membrane, and then the solutes follow. And again, we'll deep dive on that. Just to speak it out loud, because there's a lot of abbreviations and they're somewhat similar. One of those abbreviations is CRRT, Continuous Renal Replacement Therapy. And this is an umbrella term for which CVVH, Continuous Veno-Venous Hemofiltration, as well as CVVHD, as well as CVVHDF all fall within the umbrella of CRRT. So these are all three of these are types of continuous renal replacement therapy. just in case that was confusing to anybody. Okay, how does CVVH work? Well, just to speak it out loud, the step-by-step process here, which many of us probably know, is blood is first removed from the patient using a large venous dialysis catheter. This is often in like the internal jugular vein, sometimes in the femoral vein, sometimes in the subclavian vein, but it pulls blood out of a vein, so it's venous, as we've talked about. That blood is pumped, so there's a pump that pumps blood through a hemofilter, right? Filtration, which we talked about. That hemofilter has a pressure gradient, and that pressure gradient pumps water, and then the solutes follow. Again, we're going to talk about all this in more detail. After it goes through that filter, there's waste that is discarded, called effluent, and then what is not discarded is joined by a replacement fluid, and this is usually some bicarbonate buffered solution or lactate buffered solution, which then gets pumped back into the veins of the patient. Obviously much more complex than this, but just kind of a simple model for how this might work. So the key mechanism and the thing we keep talking about is a concept called convection. And convection is solutes move with flowing water. So in CVVH, there's a filter. And that filter is exposed to a pressure. So blood is pumped to this filter. We'll just label the filter with F. And that blood creates a pressure against the filter. And that pressure causes water to flow across the filter to some percentage. And as water's flowing across that filter, solutes will follow to some degree, right, and move across the filter as well. And then this combination of water and solutes that moved across the filter is discarded in the effluent. So that is convection. That's in comparison to the other modality of continuous renal replacement therapy, which we'll talk more about. So CVVH uses convection. This is a really important principle because this is one of the primary ways that differentiates CVVH from other modalities of continuous renal replacement therapy. So just to read it out loud, in CVVH, pressure pushes some amount of plasma water across a filter membrane. Solutes then get dragged along with that plasma water, a concept known as solvent drag, and that's how it removes waste. Fluid and solutes get pushed out of the blood across this filter, and then that is discarded as waste. An everyday analogy which we like is a coffee filter, right? You got a coffee filter, and that coffee filter is filled with coffee grounds, and then you pump water into this coffee filter, and it creates a pressure. And that pressure causes some of that water to come through the coffee filter and take some of the small coffee solutes with it, right? Some of the small coffee molecules. And then that is what creates your cup of coffee. So in this analogy, the blood is the coffee mixture, okay? The hemofilter is the coffee filter, and the pressure pushes fluid through, solutes follow, making coffee, all right? Obviously not a perfect analogy, but it does make some sense if it helps you conceptualize things to some degree. All right, so what happens during this process of convection in CVVH? Well, there's a semi-permeable membrane, and this is the filter. We're really trying to reinforce this concept, so we're talking about it a couple different ways because it's important. And a pressure gradient develops across that filter between the blood that's being pumped into the filter from the body, okay, and then the waste. And the waste is on the other side, and this waste will end up getting discarded as effluent, okay? So the blood comes up against this filter and it creates a pressure across the filter. Plasma water, literally H2O molecules, plasma water, gets driven across the semi-permeable membrane by the pressure that is created across it. Okay, so that pressure is creating, driving water molecules across the filter from the blood into the waste. And this is kind of similar to how a glomerulus actually works. But the interesting thing here, just like with a glomerulus, is you have all these small solutes. And there's a concept known as solute drag, or solvent drag. And that is when water is pumped through this filter, some percentage of solutes that are small enough will get dragged with the plasma water into the waste. And that's why the waste will have both plasma water as well as different solutes. And the amount of solute and which solutes come across this membrane is known as dependent on an equation, which is a coefficient based on the size of the solute, how much it participates in this drag concept with water, and every solute's different. Some of them cross very readily, very easily, like urea. Others don't cross at all, like albumin, or don't really cross at all. And it depends on a handful of things. But that is how convection works. So small solutes move really easily across this filter. Small solutes in CVVH are really easily filtered out. Middle molecules also move pretty well, okay? Large proteins, though, don't cross the filter. They don't pass through. They don't go into waste. They remain in the blood and get returned to the body. This is like albumin, right? Albumin's a big protein, and albumin is not filtered across this membrane in CVVH. Waste fluid is then discarded and replacement fluid is added. We talked a little bit about that. So this is obviously a zoomed in thing, but if you picture after this blood comes against this filter, what is not filtered across this membrane into waste will actually then return to the patient's body. But usually there's a replacement fluid that is pumped in because we want to regulate how much volume is being removed from the patient. So, you know, if we are wanting to remove, we're just making numbers up. Let's say we want to remove 50 cc's per hour of fluid from the patient's body. So when we're doing dialysis, we want them to be net negative 50 cc's per hour. So what we're returning to the body, we want it to be 50 cc's less than what we're taking out. Well, if we're doing CVVH and let's say it's running at 150 cc's, you know, per minute, and it's going through here, and of that 150 cc's, we're just making these numbers up. Let's say 10 cc's are discarded in waste. Well, if it's 10 cc's per minute, and there's 60 minutes an hour, that's 600 cc's that are discarded as waste, but we only want them to be 50 cc's negative per hour. So then we're going to give 550 replacement fluid, right? So that there's 550 cc's of replacement fluid returning back to the patient's body, and of the 600 cc's that's wasted, minus 550 cc's that we're returning to the patient means there's 50 cc's total that it is discarded per hour and not returning to the patient. All right, so that's where that replacement fluid comes in. And again, this is usually a bicarbonate solution with some variability depending on the institution you work at. All right, why does convection remove certain solutes better? Well, we've already talked about this a little bit, but convection removes solutes based on size and membrane permeability, not concentration gradients. And this is important because concentration gradients are how dialysis works. There's an actual dialysate, and if you're interested in this more, again, just check out our other episodes that look at hemodialysis or hemodiafiltration. But there's no concentration gradients involved in convection, involved in CVVH. It's all based on the transmembrane pressure and what that semi-permeable membrane is, and then the solute size, all are what are going to contribute. So CVVH removes well, right? We said small solutes, and even some medium-sized solutes. And that's going to be things like urea, creatinine, potassium, lactate, different small molecules, even middle molecules such as cytokines. But CVVH does not remove large proteins like albumin. They're too big to cross the membrane. So you will not lose albumin while being on CVVH. Convection versus diffusion. Diffusion is what we talk about with dialysis. Diffusion is what we talk about when we talk about concentration gradients. Diffusion is not involved in CVVH, but diffusion is involved in CVVHD and CVVHDF and hemodialysis as well. So anytime you see dialysis, it's diffusion. Anytime you see filtration, it is convection. So we'll just write that. Convection is always filtration. Diffusion, dialysis, at least for the sake of these episodes. All right, so understanding this explains most CRRT differences. We already talked about convection, right? Convection, as we have said several times already, is when solutes move with water flow driven by pressure across that semi-permeable membrane. It's good for small and middle-sized molecules, and clearance depends on the fluid removal rate, because that is what's going to create the pressure gradient. So it's flow-dependent clearance. Diffusion, on the other hand, which we'll dive more into in our episodes on CVVHD and CVVHDF, but diffusion is where solutes diffuse down a concentration gradient. The movement of those solutes is driven by the concentration differences between the dialysate and the blood. So that's best for small molecules. But again, we're not going to dive into that in this episode, but we certainly will talk about it in the episodes on CVVHD and CVVHDF. So quick comparison between diffusion and convection. The driving force in convection is pressure. The driving force in diffusion is a concentration gradient. The mechanism of solute removal in convection is solvent drag. In diffusion, it's passive movement along that concentration gradient. Convection does remove middle-sized particles. In diffusion, it doesn't really. And convection does depend on fluid flow. In diffusion, it doesn't. So why is convection ideal for ICU patients many times? Well, CVVH is continuous therapy, slow fluid removal, which means it's more hemodynamically neutral, which is important in unstable patients. There's minimal osmotic shifts, less hypotension, predictable clearance. All that is good stuff. All right, a couple more things here to really drive home a couple points. One is a concept that is based on net fluid removal and ultrafiltration. And the reason we want to bring this up is to tie in that replacement fluid, if you remember. So the ultrafiltration is how much plasma water crosses that filter. So again, let's just say we have a patient here. Their venous blood goes to the filter and then comes up against the filter, and whatever's left returns to venous blood. And you have your waste over here. And let's say that this filter filters off. Again, we'll just make up numbers. Here, it filters off 10 cc's per minute, which means every minute there's 10 cc's that go into the waste and is discarded. So what that means is the ultrafiltration that you're getting is this 10 cc's per minute, or over an hour, you could say 600 cc's of ultrafiltration per hour. But that's not necessarily net fluid removal, because before returning to the patient, you're going to get replacement fluid that is added. And that replacement fluid is taken into account for the net fluid removed. Because, again, if you're filtering off, if you're having ultrafiltration of 600 cc's per hour, but I'm also replacing with replacement fluid 600 cc's per hour, the net fluid removal is 0, right? 600 are going out, but 600 are going back in. Whereas if I am ultrafiltrating 600 cc's per hour and I'm replacing 500 cc's per hour, the net fluid removal is 600 minus 500, right? Equals 100 cc's per hour of net fluid removal. So the ultrafiltration is what is being filtered out of the blood. But that's not necessarily the net fluid removal, because net fluid removal has to take into account the replacement fluid. All right, hopefully that makes sense. It's a little more of an advanced topic. So CVH can clear toxins and solute without actually removing any net volume, because you can give as much fluid back in replacement fluid as you are filtering off in the ultrafiltrate. So replacement fluid, again, helps us maintain hemodynamics, replace electrolytes, prevent hypovolemia, control clearance, all obvious stuff. So where's the replacement fluid given? Because the plot is a little bit thicker. So if we draw a person, if you're listening to the podcast version, we're just drawing a terrible stick figure. Apologies. You run it through, you take blood out of this patient, you run it through a filter, and you return the blood back. Well, you can actually give the replacement fluid pre-filter, right? So you can add the replacement fluid to the blood before it goes through the filter, or you can add it post-filter. And there's no right or wrong. Each one has pros or cons. A lot of places do both pre and post filter, but pre-filter replacement helps you not clot this filter. Anyone who's worked in ICUs knows all about the circuit clotting, which can be a huge pain in the butt. So if you give pre-filter replacement fluid, there's less clotting of the filter because that blood is more dilute when it gets to the filter, right? Because you're adding sterile replacement fluid to the blood before it goes to the filter. But you're going to get slightly lower clearance because you're diluting out that blood before it gets to the filter. So, if you're filtering 10% of the fluid that gets to the filter, but you've diluted that fluid, you've doubled that fluid volume with replacement fluid, you're still just filtering 10%, which, again, just to make up numbers because sometimes it's easier, 100 cc's of blood goes to the filter, but you add 100 cc's of replacement fluid, and this filter is still filtering off 10%. Well, instead of 10% of just 100 cc's of blood, which would be 10 cc's, you're doing 10% of 200 cc's total, right? Which only half of that is going to be the blood, if that makes sense. So you will have less clearance of solute if you have pre-filter replacement, but you will have less filter clotting. Post-filter replacement, you have better clearance because it's all blood being pushed through this filter. It's not diluted out, but you'll have higher clotting risk. So many systems use both. There's no right or wrong, but that's kind of the rationale for pre- and post-filter replacement fluid. All right, physiology behind CVVH. We're going to fly through this because we've talked about these concepts. This is hopefully just to bring it home. The physiology here is all about the transmembrane pressure gradient across the filter that drives filtration. Higher pressure means more filtration, although very high pressure can increase clotting risk. How much solute crosses that membrane depends on the sieving coefficient, which is based on solute size, as well as the membrane itself. And a higher sieving coefficient, aka 1, means it's just freely filtered. That's like urea. Lower sieving coefficient, meaning 0, means it's not filtered, such as albumin, that big protein. And CVVH is hemodynamically gentle because it's continuous, it's slow, it's often much stabler for blood pressure. So when is CVVH most useful? Hopefully you're starting to plug some of this in. Hemodynamically unstable patients, right? They're in shock. They can't tolerate a lot of big fluid shifts. They might have severe fluid overload because you can really control how much fluid you're getting off, right? If I want net fluid removal of 200 cc's per hour, and remember, this is different than ultrafiltrate. This is net fluid removal, so it takes into account the replacement fluid. I can have 200 cc's per hour come off, and then over, 24 hours, I'm taking off. Our math's going to be horrible, but something like, 4.8 liters of fluid removed in a single day. Whereas if you do intermittent hemodialysis, it'd be really hard to get that many liters off in one day because you'd probably end up causing some hypotension. Usually it's kind of 2 or 3 liters off with IHD, so you can get a lot of fluid off with continuous renal replacement therapy, CVVH included. Life-threatening electrolyte abnormalities, because you can be very targeted with your electrolyte changes. Now, to be fair, intermittent hemodialysis is actually a better modality for severe electrolyte derangements because it's faster. It corrects the electrolytes faster, so IHD would be a better modality, but it's more hemodynamically unstable. And then severe inflammatory states, there's some, talk about whether cytokine removal with something like CVVH can help sepsis. There's no good evidence on this that we're aware of. Here, we even put it in there, evidence remains mixed, but just something to keep in the back of your mind. So we wanted to take a minute and just go over some CVVH and CRRT terminology. We're going to compare it back to what we have talked about with CVVH, because again, there's a lot of terminology and a lot of it is actually quite confusing. So the first word you've probably heard us say is effluent. We call it the effluent. Let us know if you call it something different. This is the total fluid removed from the circuit. Okay, this includes the ultrafiltrate, and the ultrafiltrate is how much plasma water from the blood is being removed. And this includes the waste fluid leaving the filter. So if you had replacement fluid pre-filter that is being filtered across, the effluent would include that as well. And this helps determine the CRRT dose. So the effluent is the ultrafiltrate plus any other waste that is being removed from the filter. That is the effluent. To then speak it out loud, ultrafiltration, the ultrafiltrate is how much plasma water crosses that filter, which is a part of the effluent, but the effluent also can include things that aren't the ultrafiltrate, such as replacement fluid and other waste. Net fluid removal, which we have talked about, is the actual volume removed from the patient, right? Which is really the ultrafiltrate minus how much replacement fluid is being added back post-filter, we should say. Adding back to the patient, that's the net fluid removal. The replacement fluid we talked about is a sterile solution used to maintain volume in electrolytes, and it can be given either pre-filter or post-filter. The blood flow rate is the speed of blood flowing through the circuit. And this varies a lot, but it's often somewhere like 150 to 250 cc's per minute. Okay, so kind of right around 200 cc's per minute of blood flow rate through the filter. But just know that is not the same as ultrafiltrate, right? Because not all these 200 cc's per minute are being filtered through the filter, right? Only a smaller percentage of it. And then clearance is just the efficiency of solute removal across this filter. When we talk about CRRT dose, this is the plasma cleared per hour, and usually you target something like 25 cc's per kg per hour. This is an advanced topic, one we're not going to dive too much into in this episode, but we just wanted you to know that that terminology exists. Similar to the filtration fraction, which is the percentage of plasma water removed, right? Because we said the blood flow through the filter can be something like 200 cc's per hour, but not all this turns into ultrafiltrate. Not all this moves through the filter to the waste. So the filtration fraction is the percentage of this plasma water removed, and we like to target less than 25% often. So just to put that into context, of that 200 cc's per hour, let's just say for the sake of ease, the filtration fraction is 20%. That means that, only about 40 cc's per hour are actually being filtered through the filter and becoming ultrafiltration and being wasted, if that makes sense. All right, the hemofilter is the actual filter membrane. Convection, we talked about solute movement with the flow of water, which is the modality that CVVH uses. And then diffusion, we haven't talked much about in this episode because that's more CVVHD and CVVHDF. But this is a concept when solute movement moves down a concentration gradient. All right, we're going to just leave this here, this basic CVVH prescription. This is just for educational purposes. Obviously, do some reading, look stuff up, look at guidelines, look at institutional stuff. But we just wanted to put an example here for anyone interested. And again, these study guides and PDFs are on our Patreon page for all of our patrons to just access and download and do what they'd like with. All right, complications of CVVH. A big one that we have, mentioned in passing is filter clotting. Remember that sometimes pre-filter replacement fluid can decrease filter clotting. Also, access dysfunction. You need kind of large bore catheters in patients' veins to do continuous renal replacement therapy, such as CVVH. So you can have, bleeding and infection and, complications of placement and all that. And then blood loss in the circuit. Right? You're moving blood through this circuit, and if the circuit clots, you can't really return clotted blood back to the patient. So you got to waste all that blood that's stuck in the circuit, so you can have blood loss. And then this is something to be really aware of. A lot of us have excellent pharmacists who help us navigate this, but many drugs are removed using CVVH, right? Drugs, just like small solutes, can pass through that membrane. So drugs sometimes can end up in the waste portion of CVVH, some antibiotics, sedatives. So always reassess dosing and just know that renal replacement therapy does affect dosing. All right, we're getting towards the end. Some high-yield clinical pearls here. CVVH uses convection and solvent drag. It removes small and middle-sized molecules. It's great for hemodynamically unstable ICU patients. It's continuous therapy, so it causes less hypotension. Clearance depends on the ultrafiltration rate. Replacement fluid location affects the efficiency pre or post-filter. And then hypophosphatemia is common. We often lose phosphate in these modalities, so something to keep a close eye on. All right, all we have left are some practice questions. We already showed you the first answer. If you're watching the video form, sorry. If you're listening to the podcast, you didn't have the ability to see the answer for question 1. But for those of you that have not done practice questions with us, how we do it is we read the question, read the answer options, and then we just go right into the answer. So if you need more time to think about it, just make sure you pause the episode because we'll just jump right into the answer. So question 1, what is the primary mechanism of solute removal in CVVH, or continuous venous hemofiltration? A, diffusion, B, convection, C, osmosis, or D, active transport? Correct answer, pause it if you need to, is B, convection, right? Remember, CVVH is hemofiltration. Anytime you see filtration when it comes to dialysis stuff, think convection. And remember, convection is that solvent drag where the solutes follow the water, H2O, which both can go through the filter based on the transmembrane pressure across that filter. All right. Question 2. What is CVVH preferred? Why is CVVH preferred over intermittent hemodialysis and septic shock? A, faster toxin removal. B, better potassium clearance. C, less hemodynamic instability. D, lower infection risk. Correct answer is C, continuous therapies prevent rapid volume shifts and hypotension. So there's less hemodynamic instability with CVVH over intermittent hemodialysis. And that would be true of all continuous renal replacement therapy modalities as compared to intermittent hemodialysis, which is much more hemodynamically taxing. All right, question 3. Which solute has a sieving coefficient closest to 0? A, urea, B, creatinine, C, potassium, or D, albumin? And as a hint, 0 means less, right? Less, wow, we're totally blowing this. Less filterable, question mark. So the correct answer is D, albumin, right? Large proteins do not cross the membrane, so their sieving coefficient is low, albumin being close to 0, so it doesn't like to filter through. Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today we're going to be diving in to another part of renal replacement therapy. We've done a whole bunch of episodes on renal replacement therapy. Now you can find them linked in the playlist under nephrology. Also, if you just search Whiteboard Medicine renal replacement therapy, they'll all pop up. But today's topic is continuous veno-venous hemodialysis, CVVHD. And this is part of that umbrella of continuous renal replacement therapy, right? So with continuous renal replacement therapy, CRRT, there's CVVH, which is continuous veno-venous hemofiltration. There's CVVHD that we're going to talk about today, which is continuous veno-venous hemodialysis. And then there's actually CVVHDF, continuous veno-venous hemodiafiltration. All this probably sounds confusing. Well, that's why we got the episode here today. So by the end of this episode, you're going to have a full comprehensive understanding of what CVVHD is, how it works, when to use it, risk-benefit, adverse effects, all that good stuff. And we'll kind of do an overview of different definitions and terminology as well. So no further ado, let's dive in. What is CVVHD? Well, as we already mentioned, CVVHD stands for continuous veno-venous hemodialysis. All right. And that's a type of continuous renal replacement therapy, as you heard us already say, that removes solutes primarily through, and this is important, through diffusion. Okay. This is in contrast to CVVH hemofiltration, which does not use diffusion in a dialysate. Okay, that uses solvent drag, which we talked about in that previous episode. All things to check out. So CVVHD hemodialysis uses diffusion, and to use diffusion, you need a dialysate that you're adding to the circuit. This is all stuff we're going to get into more. So this is just kind of the introduction to it. So if it doesn't make sense, it will by the end. And what happens is you pull the blood out of the body and you run it through a chamber. And that chamber has the blood flowing through. It has a semi-permeable membrane, and then it has dialysate. And what happens is the solutes in the blood diffuse into the dialysate depending on the concentration gradient of the dialysate. So it provides continuous clearance of small solutes and fluid in critically ill patients, especially those with hemodynamic instability, and we'll get into all that. So just to kind of take it home to the introductory core concept here, CVVHD removes waste by allowing solutes to move from blood into dialysate down a concentration gradient, from high concentration down to a low concentration. And if the terminology is confusing, which it is, the thing to remember here is anytime you see filtration, this is going to be using that solvent drag. Anytime you see, if I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients. Anytime you see dialysis, it's going to be using diffusion and a dialysate. So that's the kind of secret to the terminology here, right? Continuous veno-venous essentially just means you're pulling blood out of a vein, you're returning that blood to a vein, and you're doing it continuously. So you can even really kind of forget about the continuous veno-venous, the CVV portion, and just focus on the hemodialysis. Same thing with all these, right? CVVH, focus on the hemofiltration. CVVHDF, focus on the hemodiafiltration. So the continuous veno-venous is just pulling blood out of the vein, returning it to a vein continuously. All right, let's get into how CVVHD works. Well, what happens is you have a large dialysis catheter in a vein, and this can be in a lot of different veins. If we draw a little person, if you're listening to the podcast version, which we'd recommend, all these episodes end up in podcast form, you won't see our terrible drawing here, it's just a stick figure. But you have to have a large dialysis catheter in a big vein. Often this is the internal jugular vein in the neck. It could be the subclavian vein that runs under the clavicle. It could be the femoral vein in the groin. But you have to have a large dialysis catheter in one of these veins. And what you do is you pull blood out of that vein and you pump that blood through a hemofilter. So a big kind of chamber. And in that hemofilter, there's the dialysate. So we'll kind of draw a semi-permeable membrane. At the bottom of this hemofilter, there's the dialysate. And the blood travels through this hemofilter above the semi-permeable membrane, adjacent to the dialysate. And the blood flows in one direction, and the dialysate flows in the opposite direction within this hemofilter. And what that means is that as this blood travels, solutes within the blood, so if we were just kind of zoom in on this hemofilter, you have the semi-permeable membrane, and you have your dialysate, which has, some concentration of solutes, which you can choose and set. And then you have your blood, which has even more of those solutes. And what happens is these solutes travel through the hemofilter until these concentrations between the blood and the dialysate equilibrize, they equal, so there's no longer this diffusion gradient. But the diffusion gradient is always kind of resurfacing because the dialysate flows this way. So the dialysate never kind of gets to higher concentrations of solute, even as solute from the blood flows in the dialysate, because the dialysate is constantly flowing through this hemofilter. kind of re-energizing that diffusion gradient. And the blood flows the opposite way, flows in that direction. So as blood flows, solutes from the blood diffuse into the dialysate, and that dialysate flows as well, kind of getting rid of the solutes from the blood that's in the dialysate and replenishing and re-energizing that concentration gradient. All right, the waste fluid is then discarded, right? The dialysate is discarded, and the blood then returns to the patient through the same big dialysis catheter, because it's got two big ports. You know, if this is the catheter, there's two big ports. One sucks blood out, one returns blood back. All right, unlike CVVH hemofiltration, replacement fluid is typically not required for solute clearance. And what this essentially means is in CVVH, which we talked about in its own episode, and again, highly recommend you check that out. Just search Whiteboard Medicine CVVH. But in CVVH, there's not this dialysate. There's still a filter, there's still a semi-permeable membrane, but there's blood that is pumping into the filter, and the pressure from the blood being pumped in this filter pushes some fluid through the filter, and solutes then follow that fluid. It's called solvent drag. But because you are losing fluid and solutes more readily in CVVH, you usually then add a replacement fluid to try to kind of get the appropriate volume returned to the patient. Whereas in CVVHD, you don't tend to have to do that. So the key mechanism in CVVHD, continuous veno-venous hemodialysis, is diffusion. And we talked a little bit about it, but let's dive into it more. What is diffusion? Well, diffusion is when solutes move from a high concentration to a low concentration across a membrane. And in CVVHD, blood contains the high concentration of waste. That's why you're running them through a dialysis circuit. The dialysate contains a low concentration of waste, and solutes move down that gradient. So again, if we were just to kind of spell it out one more time, because this is a really important foundational concept, and if you have an interest, all of the study guides and PDFs from these videos are all uploaded to our Patreon page. You can access them all there as a paying member. So if you want to download this study guide, take notes, take it with you, what have you, definitely check that out. It's linked in the episode description as well as the pinned comment on YouTube. Okay, so the blood has a high concentration of waste and solutes. So let's just say there's 10 solutes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 in the blood. Blood's up here, B for blood. In the dialysate, on the other side, there might just be 4 of these solute molecules. So what the blood and the dialysate and all these solute wants to do is they want to equilibrate. So the solutes will flow from high concentration in the blood through the semi-permeable membrane into the dialysate. They'll diffuse down there to try to equilibrate the amount of solute in the blood in the dialysate. But as we said, the dialysate is constantly flowing through, so you never can equilibrate, and the blood's constantly flowing through as well. But it's that diffusion across this concentration gradient from high concentration in the blood to low concentration in the dialysate. And in the dialysate, you choose the concentration within that dialysate prescription. So if you want to clear a bunch of solute, you make that concentration low. If you want to clear less, you make it a little higher, etc. So an everyday analogy, if this makes sense, you'll have to let us know in the comments. We thought it was a nice one, but an everyday analogy might be like a tea bag in water. Tea particles move from inside the bag into the water because the bag, which would be kind of the equivalent of the blood, has a high concentration of tea, and the water, which would be equivalent to the dialysate, does not have any of those tea solutes. It has a low concentration, so they flow from within the bag, which is the filter, into the water, which is the dialysate. So CVVHD works similarly. Blood is the tea bag, the dialysate is the surrounding water, and solutes spread from the tea bag into the water, diffusing across the concentration gradient from high concentration to low concentration. So what is actually happening during diffusion? Blood is flowing through the filter in one direction. The dialysate is flowing through the filter in the opposite direction, and that creates a concentration gradient that then those solutes move from the blood into the dialysate. There's no pressure required. It's a passive process, and then you just discard the dialysate. Cool. What does diffusion remove well? Because diffusion and this process in hemodialysis, continuous veno-venous hemodialysis, this process does not remove all solutes well. It really is the most effective for small molecules, things like urea, creatinine, electrolytes like potassium, even lactate, and other small electrolytes. So small molecules are really important here. CVVHD does not remove large proteins like albumin. It won't remove any albumin, okay? I shouldn't say any, but it won't remove much albumin. It also is less effective for middle-sized molecules, whereas middle-sized molecules are better filtered in hemofiltration mechanisms rather than hemodialysis mechanisms, because these middle molecules won't diffuse well across that semipermeable membrane by the concentration gradient. So CVVHD removes small molecules well, which is what you typically are doing when you're doing dialysis. You want to remove urea and creatinine and electrolytes and lactate, right? Equilibrate your acid base. Whereas this isn't a good modality if someone's overdosed on something, what have you. All right, just talking about diffusion versus convection, because this is the big difference here. So convection is that solvent drag we talked about. And that is when the filter, this is like CVVH hemofiltration. Remember, hemofiltration is convection, it's solvent drag. But that semi-permeable filter, you actually are pumping blood up against it and creating a pressure. And that pressure is pushing fluid through the filter, and that fluid then drags solute molecules with it. All right, so CVVHD, hemodialysis. Remember, dialysis is diffusion. That is driven by the concentration gradient, best for small solutes. The dialysis flow rate is what establishes the concentration gradient, and you can change that flow rate. And this is passive movement. It's gradient dependent. Whereas convection and hemofiltration mechanisms like CVVH hemofiltration, solutes are driven across the membrane by water flow, which is driven by pressure, right? And that's better for middle-sized molecules. And there's flow-dependent clearance and ultrafiltration and some of these kind of more complex things that we covered in our CVVH episode. So that's the comparison between the two of them. We have a little table comparison here. Remember, you can access this, download it, edit it, take notes on it all on our Patreon page if you want this table. But between CVVHD, which is what we're talking about today, right? That's dialysis, that's dialysate, that's diffusion, versus CVVH, which is filtration, which is convection and solvent drag. So the driving force in HD is the concentration gradient. The driving force in hemofiltration is the pressure. Small molecules are excellently removed in CVVHD, right? It's very effective for small molecules. CVVH, hemofiltration can do it too, just not as well. But middle molecules aren't well removed. Middle-sized molecules are not well removed in CVVHD, whereas they are fairly well removed in CVVH. And then CVVHD hemodialysis requires a dialysate. CVVH does not require wow, shame on us, dialysate. All right, in the ICU, we use a lot of these continuous renal replacement therapy modalities. Obviously, the one we're talking about today is CVVHD, and it's really nice because it has continual clearance, right? It's continuous renal replacement therapy, continuous venous hemodialysis. You can have very precise electrolyte control because how you set the dialysate flow rate and that concentration gradient to equilibrate can help you really target certain electrolyte concentrations. Minimal hemodynamic shifts because you're only pulling out, you're not trying to pull out liters and liters and liters like you do in intermittent hemodialysis, IHD, which is not something we're talking about today, right? We're talking about continuous renal replacement therapy. IHD is outside of continuous because IHD is usually, something like 3-4 hours long, and you pull out dozens of liters of fluid, and you often discard a couple liters, and that's just a lot more hemodynamically intolerable. And then this is efficient for small solute removal. So that's why we like it in the ICU, these continuous renal replacement therapy modalities. And the real primary reason, all these are legitimate, but the real primary reason is probably this minimal hemodynamic shifts. If someone's on a bunch of vasopressors, they're hypotensive, they're probably not going to tolerate intermittent hemodialysis. They probably need a continuous renal replacement therapy motif. And whether that's CVVHD or CVVH or CVVHDF is a more complex question. But all four of these points, continuous clearance, precise electrolyte control, minimal hemodynamic shifts, and efficient small solute removal, are really applicable to all these continuous renal replacement therapy modalities. All right, fluid removal in CVVHD. So the ultrafiltration This is not the main clearance mechanism in CVVHD. Okay, the ultrafiltration is the fluid being removed, the ultrafiltrate, the UF, you'll hear us say. And this is used for volume control and fluid balance, right? If we're dialyzing someone, one of the reasons might be because they're not making urine and they are fluid overloaded. They're in renal failure, so we need to get fluid off of them. And that fluid we remove is called the ultrafiltrate, the UF. And in CVVHD, the fluid removal occurs by a pressure gradient, but it is not the main clearance mechanism. Remember that dialysate, that diffusion is the main clearance mechanism, whereas in CVVH, hemofiltration, the pressure gradient is the main mechanism it clears solute. So the net fluid removal is the fluid removed, obviously minus the fluid added. This is something you can, set, right? You can say, I want the ultrafiltrate to be 50 cc's per hour, or maybe 150 cc's per hour. You can literally set that on CRRT modalities, and that means that every hour there will be 50 cc's removed from the patient's circulating volume. All right, the dialysate, just to go through some more terms, is this sterile electrolyte solution. Again, hopefully we're knocking this home. It flows opposite direction of the blood, and it creates that concentration gradient to remove solutes by diffusion and control the electrolyte balance. It is countercurrent flow. Again, another term that we have talked about, right? The blood flows in one direction and the dialysate flows in the other direction. That's called countercurrent flow. And that maintains the concentration gradient and maximizes clearance. And then the physiology behind CVVHD. This is going to be kind of a culmination of a lot of things we've talked about, so hopefully this kind of cements it and brings it home. The physiology behind CVVHD is really two things: concentration gradient and membrane permeability. So concentration gradient being the difference in that solute concentration between the blood and the dialysate. Higher gradient means more clearance, and you can set this on the dialysis prescription. And then the membrane permeability is really important too, because only small molecules can cross easily. That's why we said in CVVHD, middle-sized molecules do not work that well, do not clear that well. So there's limited cytokine removal, minimal protein loss, which is a good thing for minimal protein loss. So that concentration gradient and the membrane permeability are really important for the physiology here. And then the dialysate flow rate helps you maintain that concentration gradient. All right, when is CVVHD most useful? Electrolyte control, right? We said CVVHD is really good for small molecule clearance, which electrolytes are. So electrolyte control, hemodynamic instability, which would really be applicable to any CRRT, continuous renal replacement therapy motif. Fluid overload, again, this would be applicable to really any CRRT modality because you can get fluid off the patient gently. But CVVHD, it's really ideal for small solute clearance, right? Rapid small molecule control, whether that be electrolytes or urea or some other small molecule. All right, just to revisit now a little bit of the terminology related to CVVHD and CRRT. We're going to leave this here on the study guide and PDF so you can access it on our Patreon page. We're not going to dive into all these terms because we're worried it might make things more confusing because they're kind of general terms related to CRRT, but they are referenced here if you need to kind of revisit some of the terminology that we're talking about here. All right, so basic CVVHD prescription, as always, none of this is intended to be acted upon as medical advice. All this is opinion and education targeting healthcare professionals. Please reference the disclaimer at the end of the episode or in the description. But basic educational conceptual CVVHD prescription, what are people, nephrologists or some intensivists actually putting in the chart? Well, one is the blood flow rate, right? This is the cc's of blood per minute that you're going to pull out of the patient's body through that catheter. Often it's somewhere around 150 to 250 cc's per minute. The other thing is the dialysate flow rate. This is the primary determinant of clearance. Higher flow is greater clearance because you're going to maintain that concentration gradient more readily, okay? So the higher the dialysate flow, the more small solute clearance. And then the other thing to note is anticoagulation. This is an important kind of shout out. We talked about this in some of our other continuous renal replacement therapy kind of basics and generalities. But in general, These CRRT modalities, continuous renal replacement modalities, again, for which CVVH, CVVHD, CVVHDF are all a type of continuous renal replacement therapy. They aren't inherently anticoagulated. It depends on your institution. Some institutions anticoagulate all of them, but for those institutions that don't, you can clot the circuit, right? The circuit's clotting. And if the circuit clots, you actually have to discard all of that blood in the circuit. You can't give it back to the patient. So there's ways you can anticoagulate the circuit. One is just heparin. The other one is regional citrate, where the circuit itself runs citrate. And this is another way people tend to do this. So if the circuit's clotting, think about, do I need to anticoagulate the circuit, whether that be heparin or citrate, and it probably is very institutionally dependent. Okay, complications of CVVHD. This was a nice transition, although we did not intend it to be that way. Circuit problems such as filter clotting. Obviously, these are large bore access in the patient's veins, so complications of placing or maintaining those accesses. Volume problems, hypovolemia is, we're going to just take that out. It's, if you have the wrong prescription for dialysis and if you're taking off too much ultrafiltrate, remember that's the amount of fluid not returned to the patient, then you might cause hypovolemia, but hopefully you're being thoughtful about that. And then medication clearance. The medications that you give a patient, some of them are cleared through dialysis and require drug dosing adjustments. If you're at an institution with awesome pharmacists, which hopefully most people are, but certainly not everybody, they usually will take care of this, but the dosing of certain medications needs to be adjusted for patients on continuous renal replacement therapy. All right, we're almost to practice questions, which is where you really decide if you've learned something during this episode. But coming into the high-yield clinical pearls, CVVHD hemodialysis uses diffusion, right? Best for small solute removal. Clearance depends on the concentration gradient. Dialysate flow determines that clearance and concentration gradient. This is hemodynamically gentle, but it's less effective for middle-sized molecules than CVVH, continuous veno-venous hemofiltration. All right, left now are the practice questions, where we decide if we have learned something or not. If you've not seen an episode or heard an episode with us, practice questions, we will read the question, read the answer options, and then we just go right into the answer and explanation. So if you need more time to think about it, just make sure you pause the episode, because we'll just dive right into the answer. So question 1, what is the primary mechanism of solute removal in CVVHD? A, convection. B, diffusion. C, active transport. D, ultrafiltration. All right, pause if you need to. The correct answer is B, right? CVVHD, hemodialysis, uses diffusion and a dialysate. Hopefully we've enunciated the D well enough to carry that home, right? So the correct answer is B, diffusion. Convection would be for CVVH, hemofiltration. Active transport is not a thing for these, and then ultrafiltration is just the amount of fluid discarded, which is applicable to all these different modalities. All right, question number 2. Increasing dialysate flow rate in CVVHD most directly increases A, the blood pressure, B, the solute clearance, C, the filtration fraction, or D, protein removal. The correct answer is B. Dialysate flow rate determines the diffusion-based clearance, right? Because the higher the dialysate flow, the more that concentration gradient is preserved, and the more solute that diffuses from the blood into the dialysate and is cleared. So the correct answer is B, solute clearance. All right, question number 3. CVVHD is least effective at removing which substance? A, urea, B, potassium, C, creatinine, or D, albumin? Correct answer is D, albumin, right? Because CVVHD is good at small molecule clearance, which we talked about. So small molecules include electrolytes like potassium. It includes urea and creatinine. But albumin is a big protein, so albumin does not cross that membrane. It does not remove albumin, which, again, patients need their albumin, so that is a good thing. That's a net positive, not a negative. All right, question number 4. We're almost done. Which factor most directly determines clearance in CVVHD? A, blood flow rate. B, ultrafiltration rate. C, dialysate flow rate. Or D, replacement fluid rate. Hopefully you get this one. This echoes one of the previous questions. The correct answer is C. Diffusion depends on dialysate flow rate. So dialysate flow rate is the correct answer. This most directly determines clearance, clearance being in reference to solute clearance in CVVHD. All right, last but not least, question number 5, and then we can give y'all back to your day. A patient on CVVHD develops persistent hyperkalemia despite therapy. The most appropriate adjustment is A, increase the dialysate flow rate, B, decrease the blood flow rate, C, stop ultrafiltration, or D, add replacement fluid. Correct answer is A, increasing the dialysate flow increases potassium clearance and really all solute clearance. This is one of the big themes with CVVHD, is that dialysate flow rate is what's going to really drive your clearance rate of your solutes, including potassium, creatinine, urea, etc. All right, welcome back, everybody, to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today, we are going to be completing our series on continuous renal replacement therapy, CRRT modalities, for which we have talked about CVVH, continuous veno-venous hemofiltration, CVVHD, continuous veno-venous hemodialysis, and today we're going to be talking about CVVHDF, continuous veno-venous hemodiafiltration, also known as CVVHDF. We would highly encourage you to go back and watch the episodes on CVVH and CVVHD, because CVVHDF, what we're talking about today, is a combination of these other two modalities. So by understanding those, you will have a much easier time understanding this episode. And you can just search Whiteboard Medicine CVVH, Whiteboard Medicine CVVHD, or check out our nephrology playlist. They're all in there, all linked in the episode description, etc. All right, let's dive into CVVHDF. As a reminder, before we get started, none of this intended to be acted upon as medical advice. This is all educational opinion and for healthcare professionals, so please reference the full disclaimer in our episode description. Okay, now that we got that out of the way, what is CVVHDF? So as we talked about, CVVHDF stands for continuous veno-venous hemodiafiltration. And if we break that down, it becomes a little more straightforward. Continuous just means that it runs continually, right? This is a CRRT modality. It's a continuous renal replacement therapy. Veno-venous means you take blood from out of the vein, and then you run it through the filter, and then you pump it back into a vein. It's veno-venous. Out of the vein, back into a vein. It'd be in, contrast to veno-arterial, which is something we talk about in ECMO sometimes, which goes from, an artery to a vein, or a vein to an artery. But this is veno-venous, VV. And then hemodiafiltration. And this is where those previous episodes might become helpful, because the dia in here is an abbreviation for dialysis, which uses diffusion to clear its solutes, which we're going to talk more about in this episode. And the filtration stands for filtration, which uses convection to clear its solutes. So it's a combination of dialysis and filtration, and it, as a combination, uses both diffusion and convection. And as we said, this is a type of continuous renal replacement therapy, which is the umbrella term, CRRT, and it removes solutes by both diffusion and convection. So, just to drive it home as the introductory kind of point here, is CVVHDF combines features of both CVVHD, diffusion-based clearance, and CVVH, convection-based clearance, to allow optimal removal of both small-size molecules and middle-size molecules with ultrafiltrate and discarded volume. So the core concept, it uses these two mechanisms simultaneously, where solutes move down a concentration gradient into a dialysate, which is the diffusion portion, and solutes also are dragged with filtered plasma water, which is the convection portion, that then provides the most comprehensive solute clearance of CRRT modalities. And we're going to get into all of these statements as the episode continues, so stay tuned. You'll come out of this with a really good understanding of these things. So how does CVVHDF work? What are the actual kind of steps? Well, the step-by-step process here, and if you're listening to this in podcast version, apologies. If anyone's interested, we do put all these out in podcast version. We're drawing a terrible stick figure, so you're missing out on that, maybe for the best. But all of these modalities, all these continuous renal replacement therapy modalities need to be done through a dialysis catheter, right? It's CVV, continuous veno-venous. So the dialysis catheter sits in a vein. That's sometimes the internal jugular vein in the neck, sometimes the subclavian vein under the clavicle, sometimes the femoral vein. And it's just a single catheter that has 2 lumens. One lumen sucks blood out of the vein, another lumen returns blood into that vein. So the step-by-step process here is blood is removed via a large venous dialysis catheter. That blood is then pumped into kind of a chamber with a filter here, okay? And that blood pumped through the hemofilter flows across the membrane, right? So we'll get some red here. So blood comes in here, blood is moving this way, and then on the bottom you have dialysate, okay? And the dialysate has counterflow. If you watched our CVVHD episode, you'll understand that the dialysate travels in the opposite direction as the blood. This establishes a concentration gradient, and some of the solute in the blood flows across this membrane into the dialysate through diffusion. But there's also pressure being created, and that pressure forces some of the plasma water across this membrane, for which then more solute follows that through a process called convection. So it uses both diffusion and convection. Diffusion being the motif used in CVVHD, and convection being the motif used in CVVH, and now we've combined it into CVVHDF. So solutes are removed by both mechanisms. On the other side of this filter, before it goes back into the body, you'll often have a replacement fluid added, so that you can really closely guide how much fluid you're removing from the patient. Sometimes it could be a pre-filter replacement fluid, sometimes it's post-filter, which we'll get more into. And then that's returned to the patient through their vein, and this waste fluid in the dialysate is discarded. Want to level up your medical knowledge faster? Join a community of like-minded individuals interested in emergency critical care medicine. Consider joining our YouTube members community. In this community, you will get early access to new videos before they go public, members-only videos including deeper dives, bonus content, study guides, and more, and members-only medical education posts, updates, extra learning resources, and much more. If you're serious about mastering emergency critical care medicine or just want to join a community of like-minded individuals, this is the best way to learn with us every single week. If interested, hit that join button, and I hope to see you inside the community. So the key mechanism here is diffusion plus convection. The diffusion component being that those solutes move from a high concentration in the blood to a low concentration in the dialysate, and that removes small molecules really well, urea, creatinine, electrolytes, all driven by that concentration gradient between the blood and the dialysate. And the dialysate obviously is a countercurrent flow, so blood's flowing this way, dialysate's flowing the other way, and that countercurrent flow, the speed in which that dialysate is flowing, drives that concentration gradient and drives how efficiently you're removing solute, so the dialysate flow rate, which is something you can set. The other part of this mechanism is then convection. Right? And convection is that plasma water is pushed across the membrane, secondary to pressure, right? You have a membrane and you have blood being kind of pumped up against this membrane. That creates a pressure, and that pressure causes some plasma water to flow through that semi-permeable membrane, for which solutes then follow, are dragged with that plasma water. And that is decent for small molecule clearance, although diffusion is a better mechanism for small molecule clearance. But convection is actually pretty decent for middle molecule clearance, things like cytokines, because the diffusion does not clear middle-sized molecules. Convection is what adequately clears middle-sized molecules. And just like diffusion is driven by a concentration gradient, convection is driven by pressure and fluid flow. So why does combining both of these matter? Well, you get the best of both worlds, right? CVVHDF has efficient small solute clearance, better middle-sized molecule clearance, which creates more flexible clearance control, and you can have broad toxin removal, right? Cytokine removal, certainly normal electrolyte and small molecule removal. This is why ICUs often love CVVHDF as kind of a default CRRT modality, because you get the best of both worlds. To dive into diffusion and convection a little bit more, because these are kind of the two driving physiologic standpoints. This is the stuff that's going to make y'all kind of thrive in your understanding of this stuff and be better able to, if you're prescribing continuous renal replacement therapy, or you're even describing it on rounds or teaching or navigating or what have you. This is going to set you kind of above folks who have not dove into it as much, these two concepts of diffusion and convection. So diffusion, just for those who still need a little bit of a reminder, is that concentration gradient drives small molecules from high concentration to low concentration from blood into dialysate, and convection is the solutes are being dragged with water flowing across the membrane, being driven by pressure. So we have a little chart that just kind of lays some of this out. All these study guides and PDFs are offered on our Patreon page for paying members, so you can download these, you can edit them, you can kind of take notes on them, bring them with you, all that good stuff. So if interested, and we're a big fan, obviously, but we are biased, check out our Patreon page and you can access this PDF and study guide as well as all the other ones. But the features here for mechanism for CVVHDF is diffusion and convection. It has excellent small molecule removal. It has good middle molecule removal. It uses dialysate and replacement fluid, which is a combination of both CVVH and CVVHD. In the ICU, this is really useful. Again, this is kind of the default modality that many institutions use, although every institution is a little bit different, because you have broad solute clearance, right? If you have CVVH is only decent for small molecules, right? And then it's okay for middle-sized molecules. CVVHD is really good for small molecules, but doesn't do middle-sized molecules. So combining these together, you get both small and middle-sized molecules, which gives you this broad solute clearance. You can use it for toxin removal, obviously all the normal electrolyte regulation, acid base, and all that good stuff. You get precise electrolyte control. You're able to really kind of hone in on what you want that serum electrolytes to be. It's continuous therapy, right? Just like all these CRRT, continuous renal replacement therapy. So it's very hemodynamically neutral, or I guess we shouldn't say that, but it's much more hemodynamically neutral than something like intermittent hemodialysis, which is intermittent, right? Dozens of liters flow through the dialysis machine over the kind of 3 to 4 hours that you do intermittent hemodialysis. So that causes a lot more hemodynamic changes than continuous renal replacement therapy. And there's flexible prescription options, which just means that, nephrologists or intensivists who are doing these prescriptions can use the prescription to modulate a lot of different parts of what they're looking for, right? They're looking for toxin removal, they're looking for electrolyte or acid base regulation, urea removal, fluid removal. It gives you kind of flexible prescription options to achieve your endpoint. So we just wanted to dive into a little bit of terminology on the fluid removal portion of this. For anyone who has worked in the ICU, right, you might have heard a statement called ultrafiltration, ultrafiltrate. What do you want the UF to be? And the UF, the ultrafiltrate, is how much of the blood, the plasma, you're actually taking off and not returning to the patient, right? So this is how many cc's of plasma water with solute are you taking off the patient and not returning. And in CVVHD, this is primarily pressure-driven movement across the membrane. Sorry, HDF, CVVHDF. So you have that membrane, right? And you're pumping blood, B for blood, onto this membrane. It's creating a transmembrane pressure that is pushing fluid across the membrane. And then this can be discarded as ultrafiltrate. But that's not necessarily the net fluid removal, okay? Because you can give replacement fluid. And we'll get into this more. It's actually the next section. But the actual net fluid removal is going to be the amount of fluid you remove minus the replacement fluid, right? Because that's what you're pumping back in. And that's not equivalent to the ultrafiltration rate. Always. Sometimes it is, sometimes it isn't. So the replacement fluid that we're talking about stems from the fact you want to be very targeted, strategic in the net fluid removal, right? How many cc's per hour do I want removed? Do I want 50 cc's per hour removed, 100, 150 cc's per hour, what have you? This is what we're determining. We're saying we want every hour for the patient to be net negative 50 cc's per that hour, okay? And the machine's able to do that. But it requires some of this replacement fluid, right? Because plasma water is removed during convection, and the degree in which plasma water is being removed helps drive solute clearance. So you don't just want to, if you made that, no removal, you wouldn't be able to clear solute as well. So what we use is replacement fluid. This is kind of a sterile kind of electrolyte solution that you infuse back into the blood before it returns to the patient. And that helps you be very targeted with how much you're actually removing, your net fluid removal. And you can do this either pre-filter or post-filter, right? We said that there's a patient, you're drawing blood off them, you're running it through a filter, and then you're returning it to that same patient. But what you can do with replacement fluid is you can either add it pre-filter, so before that blood gets to the filter, so then the replacement fluid runs through the filter just like the blood is, or you can give that replacement fluid post-filter, which means that the blood runs through the filter and then the replacement fluid joins that blood before it goes back to the patient. Each one has a little bit of a risk-benefit profile. So if you do it pre-filter, there will be less clotting of the filter. One of these big issues, which we'll mention later, is that these filters can clot. And when they clot, you obviously can't use them because they're clotted. Sometimes you have to discard all the blood that's in the filter. You can't return it back to the patient. Sometimes you need to replace the filter. There's all sorts of issues. So if you give pre-filter replacement fluid, there will be less clotting in the filter. And the rationale is you're diluting that blood down, right, with more fluid. So it's less kind of concentrated. But with that in mind, there's also slightly less solute clearance because you're diluting this blood down with pre-filter fluid. So you're, solute clearing the pre-filtered fluid and the blood mixed together rather than just the blood itself. Whereas post-filter replacement fluid, so the blood's traveled through the filter and then you're giving post-filter replacement fluid, you'll have better clearance because the only thing entering the filter for solute clearance is the blood. It's not diluted down at all. But higher clotting risk, as we talked about. So some pros, cons there. Every place is a little different in terms of how they do this. Sometimes you do both pre and post-filter blood. And then within this, another kind of thing to keep in mind is the dialysate, which we talked about. The dialysate and CVVHDF, we have this filter with a membrane, and on one end of this filter you have blood flowing through, B for blood, and the blood flows in one direction. On the other side of this filter, you have dialysate, D for dialysate, and that is flowing in the opposite direction, counter current. And again, we have two things going on. One is there's an increase in pressure in this blood chamber that is causing plasma water to go through this permeable membrane, which then drags solute with it through convection, right? That's the filtration portion of this. And then the other thing happening is you have the dialysate on the bottom, which leads to a concentration gradient between the blood and dialysate. So some solute is then just going across this membrane from high concentration in the blood to low concentration in the dialysate. Another part of this filtration technique is the dialysate, and this provides the concentration gradient for the dia component of diafiltration. So the dia component stands for dialysis, which is this dialysate with diffusion. All right, what is the physiology behind CVVHDF? This is just going to be an echo of a lot of these concepts we talked about, right? One portion is transmembrane pressure. This drives fluid movement across the membrane through convection, which then drags solutes. The other is concentration gradient between the blood and the dialysate, which drives solutes across the membrane through diffusion. And how well those solutes cross the membrane through diffusion depends on their sieving coefficient, which is how easily those solutes can cross that membrane during convection. So why is CVVHDF hemodynamically gentle? Because it's a continuous renal replacement mechanism, CRRT. This is slow, it's steady. There's not a ton of quick fluid shifts, which makes it ideal for ICU patients, because critically ill patients often are hemodynamically unstable. And being hemodynamically unstable, you don't want big, quick fluid shifts. So you want continuous renal replacement therapy where it can be very gentle with the amount of volume being removed. So CVVHDF, very useful for patients needing broad clearance of both small size molecules and middle size molecules. You can combine toxin control like cytokines, or someone overdosed on a medication that can be removed through dialysis. And also electrolyte and acid base and urea and creatinine, all that is well cleared with CVVHDF. So that's why it's an ideal mechanism within the ICU, even beyond CVVH and CVVHD, which are also both continuous renal replacement therapy motifs. Complications are similar to the complications to just continuous renal replacement therapy in general. Circuit clotting, you obviously need a large bore access in the vein, so the complications of putting in that access or maintaining it. Volume problems, right? You're trying to remove the right amount of volume from patients, so inadequate or too much volume removal. And then all these continuous renal replacement modalities, CVVHDF included, can filter off medications you're giving the patient. So most of institutions have great pharmacists who can help dose adjust medications for patients on continuous renal replacement therapy. And there are many medications that need dose adjustments because they will be filtered off out of the patient, right? You don't just want to give a patient a medication at a certain dose and then have half of that dose filtered off because they're on CVVHDF. All right, we're getting into high-yield clinical pearls and then the actual test of your knowledge, practice questions at the end, the time we figure out if we have, in fact, learned something today. But high-yield clinical pearls to take us home before the practice questions. CVVHDF combines both diffusion and convection. It removes both small and middle-sized molecules. It provides the most comprehensive continuous renal replacement therapy, CRRT clearance. The dialysate controls diffusion. The replacement fluid controls convection. And to explain that more, convection itself, as we said, is created by pressure gradients across the filter. But the replacement fluid that we're adding back to the patient, which is kind of a concentration of electrolytes we have decided, helps us control what we are returning to the patient in terms of solutes and concentrations of different electrolytes. And then continuous therapy in general is often much more hemodynamically neutral. All right, so quick concept summary. CVVHD hemodialysis uses diffusion, CVVH hemofiltration uses convection, and the topic we talked about today, CVVHDF, uses both diffusion and convection. Shall we figure out if we learned something? Practice questions. I think we got 5 of them. Anyone who has not done practice questions with us before, what we'll do is we'll read the question stem and the answer options, then we'll go right into the answer. So if you need more time to pause and think about it, just make sure you do pause it because we're going to jump right into the answer. So question 1, what mechanisms are used in CVVHDF? A, diffusion only, B, convection only, C, diffusion and convection, or D, osmosis and filtration. The correct answer is C. CVVHDF combines both diffusion and convection, right? Because the D stands for which stands for dialysis, and anytime we see dialysis, we think diffusion and dialysate, right? We really stress that in our Dialysate in our CVVHD episode. And then in CVVHDF, the F stands for filtration, right? And anytime we see filtration, we are thinking convection. So CVVHDF combines both dialysis and filtration, so diffusion and convection. All right, next question 2. Which component of CVVHDF provides diffusion-based clearance? A, replacement fluid, B, dialysate, C, blood flow, or D, ultrafiltration pressure. The correct answer here is B. The dialysate creates the concentration gradient for diffusion, right? If we draw this filter here and blood is flowing across the filter this way with all these solutes in the blood, the dialysate countercurrent is flowing in the opposite direction, and the dialysate concentration and rate of dialysate flow is what will maintain the high to low concentration solute gradient between the blood and the dialysate that then drives all those solutes in the blood to diffuse into the dialysate and be discarded. All right, question 3. Convection in... excuse us, big sneeze. Question 3. Convection in CVVHDF primarily depends on A, dialysate flow rate, B, blood temperature, C, ultrafiltration rate, or D, sodium concentration. This one's a little harder. We didn't stress this as much in this episode, but the correct answer is C. Convection is driven by ultrafiltration rate. Because remember, in convection, it's all about pressure across the semipermeable membrane. You're pumping blood up against this membrane, and it is creating a transmembrane pressure, and that transmembrane pressure pushes water across the membrane, plasma water, which then drags solute with it. So the ultrafiltration rate, how fast you're pushing blood up against this membrane, is going to lead to how much plasma water is being filtered off, and that ultrafiltration rate then drives how much solute is being dragged with the plasma water. All right, getting closer. Question 4. Compare with CVVHD, which is continuous veno-venous hemodialysis. CVVHDF, continuous veno-venous hemodiafiltration, provides improved clearance of A, sodium, B, urea, C, albumin, or D, middle-sized molecules. The correct answer is D, middle-sized molecules, right? Because for CVVHD, which is dialysis, which is diffusion, this does not clear middle-sized molecules because you're creating a concentration gradient across a membrane, and these small molecules flow from high to low concentration, but middle-sized molecules can't really flow across this membrane. Okay, so the way you clear middle-sized molecules is through the filtration portion, because that membrane, when you're pumping blood up against it, and water is traveling across the membrane, dragging molecules with it, middle-sized molecules will follow that water through solvent drag. All right, last question, question 5. A critically ill patient requires both aggressive electrolyte correction and removal of inflammatory mediators. Which CRRT modality is most appropriate? This is a fun one, clinically applicable. The correct answer options: A, CVVHD, B, CVVH, C, CVVHDF, or D, intermittent hemodialysis. Correct answer is the theme, right? CVVHDF, continuous veno-venous hemodiafiltration, because you will get both great electrolyte correction, right? Electrolytes are small molecules, and you will remove inflammatory mediators, which are middle-sized molecules. All right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today is going to be kind of the capstone episode to pull together the last couple episodes we have had, which have been on continuous renal replacement therapy motifs, including CVVH, CVVHD, and CVVHDF. So this episode is going to be a quick comparison. It's going to kind of list them all and compare them across different aspects of continuous renal replacement therapy. So probably very high yield and to the point. If you are listening to the audio version, a lot of the stuff is going to be visual in this one. So the video is always linked in the audio podcast description if you do want to pop over to the video, but obviously totally your choice. Also, as a reminder, this PDF and study guide, just like all of our episodes, is available on our Patreon page for our paying members. So if you want to download this study guide and take notes on it, annotate it, take it with you, what have you, that's definitely accessible there. No further ado, let's dive in. Big picture framework. Understanding the mechanism of solute removal explains most differences between these continuous renal replacement therapy mechanisms. We actually should have said this earlier, but if you have not watched the individual episodes on CVVH, CVVHD, and CVVHDF, we'd highly recommend you go back and do it, unless you already have a good understanding of these, because those are going to be deep dives on the individual CRRT modality. This is going to be an overview of them, so it might be confusing if you don't have enough kind of foundational understanding of these. Okay, so talking about CVVH, CVVHD, and CVVHDF in terms of their primary mechanism, and then kind of conceptually what's happening. Well, CVVH, as we know, uses convection to remove solutes, right? That's where that transmembrane pressure pushes plasma water across the filter, in which solutes then get dragged into the ultrafiltrate. where CVVHD uses diffusion. That's where the blood runs countercurrent to a dialysate, and the high concentration of solutes in the blood diffuse into the low concentration of solutes in the dialysate, and then you discard that dialysate. And then CVVHDF is a combination of those two. It uses both diffusion and convection. All right, so the simple concepts here are convection, diffusion, and that is how solute is removed, and that determines a lot when it comes to these CRRT modalities. Okay, so mechanism of solute removal, if we were to dive a little bit deeper, in CVVH, which is continuous venous hemofiltration, we're using convection, right? Convection is what causes solutes to move with plasma water across that transmembrane, right? So you have your membrane, you have blood that is being pumped up onto this membrane. The pressure created across the membrane causes plasma water to go through that transmembrane, and then it drags solutes with the plasma water to clear them. So the amount of, if I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients. Plasma water that is traveling across this filter, across this membrane, known as the ultrafiltrate, is what's going to drive solute clearance, and then all that's discarded. Okay? So squeezing blood through a filter is how you can think about it. This is great for middle-sized molecules and small molecules. CVVHD, continuous venous hemodialysis, uses diffusion. So unlike convection, diffusion is where you still have a filter and you still have blood, and this blood is traveling across the filter in one direction. On the other side of the filter, you have dialysate, and this dialysate is traveling countercurrent in the opposite direction of the blood. And you have a high concentration of solutes in the blood and a low concentration of solutes in the dialysate, so the solutes diffuse across the membrane from the blood into the dialysate across the concentration gradient from high concentration to low concentration, and that is how you clear solutes. So it's really good for small molecules. Think kind of tea spreading around in water. And then CVVHDF is a combination of the two, right? You get both diffusion and you get convection, and that gives you the broadest clearance possible, right? So it's great for both small molecules like electrolytes, urea, creatinine, and middle-sized molecules, right? Like cytokines or toxins. So what each modality removes best, as we kind of just talked about, CVVH is really good for small molecules. Think urea, think creatinine, think electrolytes. Where CVVHD CVVH is good for small-sized molecules, but it's not the best. CVVHD is excellent for small-sized molecules, and CVVHDF, a combination of the two, excellent for small-sized molecules. Middle molecules, like cytokines or toxins, CVVH is excellent for removal of cytokines and toxins, right? Because it uses that solvent drag across a membrane. Where CVVHD is very limited for middle-sized molecules. It does not remove middle-sized molecules well. And CVVHDF, because it has some of CVVH convection going on, it is good for middle-sized molecules, but not as good. And then none of them remove large proteins like albumin, which is a good thing. You don't want to be driving away albumin in your patients. So how do we control the clearance, right? How do you control how much solute is being cleared? Well, in CVVH, it's really that ultrafiltration rate, which is the rate at which you are kind of forcing plasma water through the filter. And then you're going to be discarding that filtered plasma water. But the rate in which you are forcing that water through the filter is going to determine the rate in which those solutes are being dragged with that plasma water. All right. Whereas dialysate flow rate is going to be the primary way you clear solute in CVVHD, right? Because how fast that dialysate is flowing countercurrent to the blood is how well you're going to maintain a concentration gradient for those solutes to then diffuse from high concentration in the blood to low concentration in the blood, right? And then CVVHDF uses both of those techniques. In CVVH, you do need replacement fluid. We talked about this in the episode. It can either be pre-filter, meaning you give, it's like the replacement fluid is like the sterile electrolyte solution. You can give it either pre-filter or post-filter, but CVVHD does not have replacement fluid classically. CVVHDF, because it's part CVVH, does. All right. And then effluent dose, which is how much you're kind of discarding. All three of them, you can get rid of fluid, right? You can discard fluid. You can take volume off of the patient. So the high yield rule here, increase the ultrafiltration rate to increase solute clearance in CVVH. Increase the dialysate flow rate to increase solute clearance in CVVHD. And then obviously for CVVHDF, it's both. Fluids used, just to be continue kind of to re-emphasize points, right? Dialysate. You use dialysate for both CVVHD and CVVHDF, anything that needs diffusion. You use replacement fluid in CVVH and CVVHDF, anything that uses convection. And then obviously you can do net fluid removal. You can get fluid off of patients in all three motifs. Clinical strengths. A lot of people say CVVH is best for middle molecule removal, right? Things like cytokines and toxins. All right. Whereas CVVHD is best for small solute clearance, like electrolytes, right? Urea, creatinine, all that good stuff, acid-base stuff. And then CVVHDF is a combination of the two. So it's best for kind of broad solute clearance. You want both middle and small molecule clearance. CVVHDF is going to be the best for that. It's often the default CRRT modality in many centers, CVVHDF, just because it's, the best of both worlds. So many centers use this as a default. Hemodynamic effects, this is all going to be pretty much the same, right? All these are continuous renal replacement therapy modalities. So they're all hemodynamically, somewhat kind of net neutral hemodynamically, which means that they're kind of slow. There's not as much fluid shift, certainly as intermittent hemodialysis, which causes a lot of fluid shifts. So hemodynamic stability is excellent for all these motifs. They're all continuous therapies. There's minimal rapid fluid shifts. They're much gentler than intermittent dialysis. So when to choose each, for CVVH, if you really are just interested in middle-sized molecule removal, let's say it's toxins, CVVH is a nice modality. If you're really just interested in electrolyte or uremia control, CVVHD is nice. If you just want broad solute clearance, CVVHDF, which again is often the default modality that is used, is the best. So high yield pearls, we're getting close to the end here. Again, this was just a quick comparison. CVVH uses convection, which is ultrafiltration dependent to clear solutes. CVVHD uses diffusion, which is dialysate dependent to clear solutes. CVVHDF uses both mechanisms. CVVH removes middle-sized molecules best. CVVHD removes small solutes best. And then CVVHDF provides the most comprehensive clearance of just solute in general and is often the default modality used in most intensive care units. All right, that's all we have for you today. Again, if you want to print out this study guide in PDF, as well as a ton of other stuff, check out our Patreon page. We're very active in our Patreon community and our YouTube members community. We're big emergency critical care nerds, and we, love hanging out with you all and providing content there. So check those out, linked in the episode description. Again, this was an overview, so check out Whiteboard Medicine CVVH or CVVHD or CVVHDF if you want a deeper dive. But either way, stay well, keep learning, and we hope to see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.